today I'm going to just keep talking, and our focus is on the standard of effective decision making. And so far, we of these six standards of a healthy work environment, we've talked about, you've had a deep dive into authentic leadership, meaningful recognition, and true collaboration. And I wanted to take a mini pause and say, we've got to remember again that my analogy of putting on glasses that are looking around our unit and looking at what the work we're doing always through this lens of a healthy work environment, everything that we do. And so far, you've learned these three components. And the important thing is to think about them like gears, that authentic leadership is going to make the gear of meaningful recognition move better, which is going to make the appropriate staff, they all go together. So we've talked about three, and today we're going to be talking about effective decision making. And I laugh whenever I hear any talk on one of these standards. It's like one of those, the Hallmark thing, and the Hallmark movies bingo card that you can watch a Hallmark movie and then you could check off all the things that are exactly the same in all Hallmark movies. Well, when you hear somebody talk about any one of these standards, you should hear something about the other standards. You should be able to do a bingo card that says, hey, effective decision making really depends on collaboration and authentic leadership, meaningful recognition to the folks that are there, having appropriate staffing and skilled communication. So you're going to hear those today because it really is important to note that this healthy work environment, when we talk about these standards, that the whole is really greater than the sum of those parts, that they all work together, that these are the components that make the environment better. So that's why it's okay to zoom into one of them and work on it and tinker it, but you got to zoom back out to keep the big picture in mind. But we're going to zoom in today. And we're zooming into what does this effective decision making mean? And this is really all of the criteria that I'm about to share. All the words on the next few slides are from the AACN, the Blue Book manual that we gave you of the definition of what are the components, what is meant by effective decision making. And really, it's empowering the people who care for patients. It's empowering the people, all the people that care for our patients, all members of our teams. And it's empowering them to be involved in decision making at every level. That's making policy, that's directing and evaluating clinical care at the bedside, that's leading our organizational operations. It's really empowering our team members to have a seat at the table. So if we think of decision making happening around the table in this metaphor, that really they have a seat at the table and they're also invited to participate, not just listen at the table, but they've got a seat there, not on the periphery of the room, but a seat at the table and invited to participate. And what does that really look like? And these are really wordy. I've highlighted some key words here that we're going to focus on is our organizations. And I think it's important to think about your hospital when you think of your healthcare organization. So you all are a site that has 3 units that are involved. It's 3 units across your hospital system that are involved in this project. So it's really important to think about that big organization. But when you look at these, I'm going to challenge you to also think about your micro organization. So your unit. And so the key things here to have effective decision making is that your organization, your macro or micro, has some values that you clearly articulate and your team members own. They know those values when they're making decisions. And that all those team members in the second bullet are in positions to make decisions, from the bedside to the boardroom, we like to say. And that the third bullet here is that those team members, not just certain professions or certain roles, but we really equip our team members, all of our interprofessional team members, with education and development so that they are good decision makers. And that's things like being able to mutually set goals, to negotiate, to facilitate, to handle conflict management, to be systems thinkers and performance improvement thinkers. So giving our teams, our interprofessional team, the skills for this. And then the last one here is that we always keep the perspectives of patients and their families as active that are incorporated. So to sum up these bullets, that we've got a sense of shared values. So when we're making decisions for our organization, that there's involvement, again, that from the bedside to the boardroom, and that includes patient and family voices, and that there's equipping that's happening, that we're preparing people to be a part of that, to have that seat at the table, and to be able to be in those in the decision-making conversations. And also that all the appropriate departments are involved, and that we have respect for the rights of everybody that's there, and levels of accountability in place, and that we're able to evaluate the results of our decisions. And so again, the summary here is that we've got involvement, appropriate department of the stakeholders, who are the stakeholders, and that they're involved there, that we respect one another. We have a lot of mutual respect, and that we've got that accountability. We are accountable to our decisions, and we can evaluate the results of our decisions. Even the results of our decisions when they're delayed, when we take too long to make them, and when we are stuck, we're frozen, that we have levels of accountability there and transparency on how it's going. And we're able to communicate that. Now, that we've talked just now on the organization, but we as individuals, of the individual people, the trees in the forest, we have responsibilities here, that we need to get the necessary skills, seek them out, master our content of what we are whatever our professional contribution we're making. We can assess situations clearly and accurately. We can share fact-based information and communicate that clearly and efficiently, and that we are actively inquiring. And I love this. This has been a real challenge in my own life, is to think about drawing a circle around myself. And first dealing, whenever I'm a part of any group, I need to draw the circle around myself and deal with everybody that's in the circle. And so in this, for effective decision making, I need to draw a circle around myself and ask, am I an active participant? Am I capable? Am I making sure that I'm a capable participant? Am I thoughtful? And am I being clear? Okay, so that's our quick summary of what is effective decision making, of being able to make these decisions at the decision making table and ensuring all the right voices are there and that they're all equipped to share. So now we're going to pivot, and I want to introduce two of my colleagues. So Dr. Wes Ely is a professor of medicine and critical care at Vanderbilt, and he's the co-director of the SIB Center that I'm a part of that you've heard about. And Joanna Stollings is a pharmacist. That's our MICU clinical pharmacist specialist. I've worked with them both clinically and in research and in advocacy. So the three of us as an interprofessional team have done a lot of different work. There's a lot of bedside work that's happening, a lot of work at the bedside, taking care of patients. And that's what I'm going to first interview Wes and Joanna. And I wish there was some way in Zoom to just spotlight the two of them, because I don't, there's a gazillion people on right now and I don't know where they are. But if you turn on speaker mode in your view, whoever's talking will be the face you see. And I find that really helpful in these large meetings because I lose people. But let me just do a quick check. Wes, are you here?
Yes, I am. And can you hear me?
Yep. Great.
Okay. And before you do your interviewing, I was wondering maybe if Joanna could just have a chance to say a few things, and then me have a chance to say a few things, and then get the interview. Is that okay for us just to kind of chime in at the beginning?
Sure.
Okay.
And Joanna, do you want to go first?
Yeah.
Sure. Yeah, I'm happy to. First of all, thank you for inviting us, Brenda, and thank all of you for tuning in today. So super excited to be here. But I think the biggest thing with regards to like a healthy work environment and like making sure everybody's at the table is like how we set up rounds, I think about like on in the MICU is like everybody gets a chance to talk. And I think that's very important. Like questions are directed to everybody there. So nobody feels like they're like the low person on the totem pole or whatever. Like no one should be afraid to talk. Like everybody's opinion is valued. So I think that's really important to think about when we're talking about like how to get input from everyone to make the best decisions.
Great. Wes?
Sure. Yes, I appreciate the introduction that you gave to the topics today. And again, my name is Wes Ely. I'm privileged to work with Brenda and Joanna. And I think I'm going to just tell you two very short stories to maybe bring to life some of the things that Brenda talked about. I remember when I was a younger intensivist, I'm 61 now. You can see all my gray hair. I've been doing this for 35 years. And I was in one of our older ICUs, and I remember around the back corner room. I can tell you exactly where I was when this happened. Just trying to describe for you how vividly this memory is. And the residents, this is prior to us developing the ABCDF bundle, prior to us having what I would consider a healthy work environment. And we were very siloed in our thought processes and the way we did things. And so I think our accountability was not great. And there was a patient in the room that was suffering from pneumonia and had a large pressure ulcer. And we were late on rounds because I said it was the back corner. So it was like the 14th or 15th patient we'd rounded on. And I was getting paged to clinic. And we were already 20 minutes past time. And after the presentation was done and we outlined what the treatment plan was, what happened in my head was, you should go in this room and see this patient. And then my head said, but the patient's delirious. They won't know anyway, and you're late. Go get to clinic because they're going to yell at you at clinic if you get too late to clinic. And I did not go in the room. I took care of this patient from the door without going in the room. And I thought, that's the end of it. I made a judgment. I made a decision. I moved on. 2 days later, when I was in the room talking to the patient said to me, I heard you 2 days ago outside my room, and I heard you planning for me and making decisions about what my care was going to be. And then you were gone, and you didn't come and see me or consult me or ask questions or review with me what was happening in my life, even though I'm life-threateningly ill. I lacked accountability that day. I lacked respect for the patient. I did not acknowledge the human dignity that this person deserved to be elevated and lifted up. Fast forward to a couple of months ago when I was rounding with Joanna on a patient who was likewise delirious and also severely critically ill on vasopressors on a ventilator. And at the end of we always start with the nurse. The nurse presented, then the intern presented, and then I and the fellow chimed in on what our plan was. And then Joanna said, great, let's go see the patient and let's see if we can get them out of bed this morning. And then I said, that's right, let's go. And so we walked in the room and the patient was lying in bed and said, I don't have any hope. And I'm very depressed about this situation. And many people have told me what was going to get me better, and it hasn't gotten me better. And because of the accountability and the interrelationship of our healthy work environment, we talked with this patient, consented the patient to try to get out of the bed, work with the nurse and the family member that was there. And on that day, that patient walked for 3 feet outside the bed and then got into the bedside chair. And the next day they walked 10 feet. The next day they walked 15 feet. And about a week later, when the patient was transferring out of the ICU, ambulatory, and off of life support, the patient said, you know what made the difference? Was that you bothered to come in and talk to me when I was hopeless, and you provided me hope by getting me out of the bed. And the reason that patient was attributing her own survival to what had happened on that one pivotal day which only happened because we had a healthy work environment and we had a horizontal playing field in terms of accountability, acknowledgement of roles, not a vertical one where I was in charge and other people weren't, et cetera. And I just thought I would share the juxtaposition of those two experiences, and I appreciate being here with all of you today.
Thanks, Wes. Thanks, Joanna. And so those are great shares that you guys both had. And I'd like to pivot, Joanna, to you and as a pharmacist. And actually, if I remember right, and we three have worked together for many years. I cover my gray, so that you can't see it. And is that you really came into pharmacy, ICU pharmacy, when it was not all units had a pharmacist. And not all units, if they did have a pharmacist, rounded on the interprofessional team. So, Joanna, share with us as a member, a professional member that has joined, that journey of joining that team, and a little bit of what I was sharing about as individuals drawing that circle. Like, how did you take your seat at the table in those rounds, and what was that like? Can you share a little bit of that journey with us?
Yes, I mean, just to give you background, I remember my very first day in the MICU at Vandy. I literally like walked up to a team and was like, "Hey, I'm Joanna, the pharmacist," and they were like, "I'm like the new pharmacist in the MICU," and they're like, "Oh, we're the oncology team." So it wasn't even the right team. Like I'll never forget that was my very first day. Anyways, I mean, I just think that it's one of those things like there wasn't a big pharmacy presence in the MICU at Vanderbilt before I started there at all. So I absolutely had to earn my stripes, for lack of a better way to say it. So honestly, just joining rounds and just not being afraid to like speak up and like to really like believe in yourself and to show that like that you were valuable and that you could and help improve patient outcomes, and so just asking things like, can we stop this antibiotic? Can we change this antibiotic? Like whatever like that I recommend specifically to improve the patient's care. And one of those things like maybe people were like a little bit resistant like at first, but one of the best things to do, and I always teach this to like pharmacy students or residents when they're rounding with me, is like people are going to disagree with you sometimes, but and that's okay. That's actually a good thing. That you what you can do is actually just send them like literature to support whatever you're recommending. So that's definitely what I still do to this day, and what I did when I was first starting. If I had a recommendation for, we'll say, 8 days of antibiotics for ventilator-associated pneumonia, and somebody was like, "No, no, I think we should do 14," then like sending them like a paper to suggest that like there is actually data that we only have to do 8 days, not 14 days for pneumonia. And it's interesting too, like something else, like when I first started here, is like my office is actually in the basement, and the medical ICU here is on the 8th floor, right? So I absolutely like sat in the medical ICU, and people would see me and they would always come and ask me questions. And now I can't always sit there, honestly, because I know everybody, and if somebody might come and tell me about their dog or whatever. Not that I don't care about their dog, but I've been there so long that people literally will text me or call me, and I will repeatedly come back to obviously to see if they have questions and things. But it takes time. It absolutely takes time. And you have to prove yourself and prove your worth. But absolutely, like even when I go on vacation now, it's funny. Like I'll come back and people will be like, "Hey, Joanna, how was your vacation?" I'll be like, "It was great." And they'll be like, "Well, yeah, we really missed you. We really needed you." So I mean, it makes you. It's nice that they like it makes you feel bad on one hand that you're gone, and they didn't like contact you. But on the other hand, obviously, it is important to take vacation. But it really shows you that you are valued and that people really appreciate like what you can bring to the table.
Now, that's fabulous. Thank you, Joanna, for sharing that story and about your journey. And I will tell you that Joanna is incredibly respected. So that drawing the circle around yourself and being capable and clear and present, I think she showed up even to the wrong team. She showed up and was going to, have a seat at the table. Now, Wes, as the physician leader in those early rounds, and this pharmacist starts joining rounds, how important has it been to hear Joanna's voice in rounds, particularly as it relates to making care decisions during drug shortages? Like, what has that been like to see that evolution of having this new role over time be a part of the team?
Yeah, as I said before, silos are all doing something important. Each a silo, has the right things that were put in a silo for a purpose, but they're disconnected. And when we build bridges to silos, that's what makes the difference in medicine because it connects each of our expertise. Joanna, as a clinical pharmacist, a PharmD, helped us bridge these silos. Brenda, I'd like to read a story, if you don't mind. I didn't have this idea beforehand, but I think I'm going to read 3 paragraphs, if that's okay. Would you give me permission?
Sure.
For everybody who's on, we have a large group of interprofessional people here today, and I'm going to share a story that will echo the role that Joanna has played or that your team members are going to play in success. And what is success? I think we have to understand who we are and what success is. Who we are, hopefully, are people who have come together in an act of service. And I wasn't going to quote this before, but it's on my mind. Albert Schweitzer, who won the Nobel Prize years ago, said, "None of you will be truly happy until you find a way to serve, a path of service." And what we're all doing on this call today is figuring out how do we serve together in a way that helps reduce human suffering. And so the story I'm going to tell you about is of a no-name nurse who had no academic fame. All she brought to the table was herself. And she wasn't widely respected necessarily. She wasn't like had some big title. She was a clinical nurse educator, and her name was Mary Ann. We call her Jet. And here's the 3 paragraphs I want to share with you. I'm reading out of Every Deep Drawn Breath. I call it EDDB. EDDB. It's a book of narrative nonfiction, and all the stories in here were recorded on a device like this. And I don't get anything from this book. All the money goes back to patients and families if you ever get to this book. But here's the story I'm going to read you out of this book. I first met Mary Ann the same day I heard about Deborah and Anthony Russo tell their story of his decline after the ICU. They were powerful reminders that we needed to succeed in getting this bundle, this humanism approach implemented, no matter what the science behind it showed. It was only useful if it reached our patients. To her friends, Mary Ann was known as Jet, and her no-nonsense, scrappy honesty seemed to fit with this nickname. The ICU teams would have no chance of non-compliance with Jet in charge. In 2014, under her leadership, the Sutter Health System in California enrolled 6,064 patients and undertook the first multi-center study of the ABCDF bundle in critical care, which was built using over 35 studies from the New England Journal, JAMA, and Lancet. When all was said and done, their project was the first to show higher compliance with the bundle yielded reductions in death, length of stay, and improvements in cost of care. And here's the last key 2 paragraphs. Jet told me how she did it. And I remember interviewing her and recording what she said. And I asked her this question, how did you do it? And she said, I went to the ICUs with my small hospital and I told them about the bundle. Here's the A and the B and the C. And I explained everything and the nurses nodded. I said, so this is what we have to do. This is the cool new stuff. They said, great. 2 weeks later, I went back and you know what they had done? Nothing. Jet laughed. I can imagine, though, she didn't laugh at the time. Trying to sell people on mortality reduction isn't meaningful to them. You have to sell patients stories. That's why I started with 2 stories today. That was exactly what we had learned, too. You must sell stories to get people on board. 3rd paragraph. Jet went on. I went to our flagship hospital, Sutter Medical Center, where there was an ICU meeting. There had to be 60 or 70 nurses in the room. I had an hour. I spent 40 minutes talking to them about how we were hurting our patients and 20 minutes on how we were going to fix it. I told them what sedation did. I told them what tying patients down in a bed did, how they couldn't talk or walk or have their jobs, or how they lost their spouse and their families, how they'd said they'd rather be dead. I had nurses crying. They thought they were doing the right thing because that's what they'd been taught. They said, we didn't know. I said, I didn't know. I'm learning this stuff too, but we're hurting people. We're breaking their brains. Jet had tears in her eyes as she remembered. She looked back at me and said, That's what got people hooked. The power of these stories that you have, that I have, that we share with one another, that's what makes the difference. And what Joanna as a PharmD and what your nurses and what we do at the bedside when we're standing next to somebody who is having the worst day of their life is that we look at them and say, this is an entire person, mind, body, and spirit. And we have to, as a team, have accountability to respect the entire person, not just their bad gallbladder, not just their bad lungs, but all of them. And the way we do that is by working together as a team. Joanna brings that, and so does the social worker, so does the chaplain. All of us together playing that role as that patient's caregiver.
Thanks, Wes. We're going to have to wrap up now and move on to our spotlight, our spotlight site. Two things that I would just throw in here at the end of this little sharing time is one of the things that was important about the organization to do is to provide some equipping. And one of the things that I watched Wes and Joanna do, and that we focused on a lot with our team, is we saw that there were some team members that were very hesitant to take their seat at the table. And sometimes they needed a script. They needed a script to come to rounds to say, this is what I'm going to share. I know, and that script was even giving them permission. You are valued here. Your voice, what you have to share is valued. I know you're a little nervous sharing. You feel like the underdog or that you might not be able to share. So here's a way to communicate clearly your side of the story. And giving them a script was a really empowering way. And I know many of your projects have some stuff like that, where you're giving a script to people. And that's a great way of empowerment. It's because or having a special order to a way that things were presented. Having, in our group at the SIB Center, and this is my last thing that I'll share, we realized that we had some really gifted team members at having good conversations. They could negotiate. You could walk out. We often joke that if we've seen Wes Ely fire a few people, and they actually walked out choosing a different job, and they didn't know they were fired. And they were the happiest people in the world. And so he's really gifted at that, but we're not all gifted at that, right? And so we've had a book club where we've been walking people through crucial conversations and that people were getting tools so that they were better negotiators. They were better at coming to the table and having the words and stuff they said. So those are just two ways of thinking of micro ways to empower the members of your team to be at the table and to have a voice at the table. So I would like to thank Wes Ely and Joanna Stollings, who are superstars at Vanderbilt, taking great care of our patients, for being here today, and for really modeling in our team what this interprofessional empowerment of one another looks like with this effective decision making. So thank you for being here today.